Thank you all for coming. I'm quite impressed how many of you are here on a Saturday. And it was nice to meet some of the patients I've seen in research. It's getting late in the day, but the good thing is that some of what I will talk about you already know and you've heard about earlier. So some of it will be repetition, and maybe, hopefully, some of it will be new to you. I will talk about genetics in DM, and again, you heard a lot about it, so we'll go through that relatively quickly, and about clinical care in DM2. So reflective to Dr. Heatwell's talk, focusing on DM1, I will focus on DM2. And of course, there will be quite a bit of overlap, but some things are very unique and specific in DM2, and I will point those out. So the 4 questions that we will come across in this talk are: what symptoms can patients with DM2 experience? And what I will say as a disclosure right up front is that you may or may not experience the symptoms that I present here, or you may experience symptoms that I do not report on and I do not include in the slides. It may be because it's rare, or maybe we don't know about yet and we need to learn about it. Why does DM cause so many different symptoms? And that's why I have to go back to the genetics. And then what testing monitoring is needed? How do you educate your doctors how to care for you? And how are symptoms of DM2 treated? And that last question will be based on the care guidelines that Dr. Heatwell commented on earlier. There are specific care guidelines published for DM2 as well that are available on that website that he commented on, the myotonic.org. So first of all, what symptoms can patients with DM2 experience? And you know that best it can be a lot of diverse symptoms, and it varies a lot from individual to individual and throughout life. But when we look at statistics and ask patients what they experience the most, for example, through the registry or in our studies, it turns out that in DM2, most often the first symptom is related to the muscle. And lower extremity weakness, so leg weakness, leg pain, thigh pain, and myotonia are oftentimes the first symptoms. But patients with DM, and as you know, have GI symptoms, cataracts early in life. Breathing is less affected compared to DM1, but can be affected. And of course, the heart is important with conduction abnormalities. Brain fog or difficulty thinking with memory, again, considered less common in DM2 than in DM1, but I hear a lot from patients with DM2 that they feel that their thinking and memory is not quite as it used to be, and more studies are needed in that field. And then diabetes is a big one, and then sleep regulation and hypersomnolence, daytime sleepiness. And that's a great topic late in the afternoon after having a full day of talks. So that's what we'll think about. But now, why does DM cause so many different symptoms? And let's go back to the root cause of the disease that will give us the answer. As you know, myotonic dystrophy is a genetic condition, which means that there's a problem with the genetic material, as you know. And you know we are all made out of genes that carry instructions how to make proteins, and proteins make up our bodies, as Dr. Thornton pointed out. And so the genes carry information about eye color and hair color, et cetera, but if they carry abnormal information, that can cause disease such as myotonic dystrophy. And the gene that's causing the trouble in DM1 is on chromosome 19, and the gene that's causing trouble in DM2 is on chromosome 3. But now let's take a really good microscope and close in on those chromosomes and take a look at one of those chromosomes, the 19, the DM1 chromosome. And when you look real close, you see that the gene is made up of DNA, and DNA is made out of nucleotides, and we label them with letters, CTG, and that was outlined in Dr. Thornton's talk. And it's normal to have this repetitive pattern of CTG, but it's not normal to have too many of them, greater than 50, and as you heard, in the hundreds and thousands. And if you have too many of them, it causes DM1. Now, shifting over here to DM2, chromosome 3, we take a really good microscope and scan in here on the chromosome and look at the gene that's made out of DNA. And here, similarly, too much information on the DNA is causing DM2. The difference is it's not CTG, it's CCTG. So it's 4 letters that's causing, the 4 letters that's making up the repeat that's expanded. And those, so there's some similarity but some differences on a genetic component. So now, why does this cause a problem if there's too much information on the gene? And as you heard from Dr. Thornton, the DNA is, a copy is made from the DNA, which is the RNA, and the RNA is a little bit more mobile and can travel from the nucleus into the cytoplasm of the cell, and there serve as a template to build the proteins. So now, if the copy is made from the DNA, if the copy is made of a gene that has too much information on it, too much repeat expansions, the copy of it also has too much repeat expansions on it. So the extended DNA is transcribed into extended RNA, and that too much RNA actually forms clumps that you saw in a different visualization earlier in Dr. Thornton's slides. And so you think about it, well, clumps in the nucleus of a cell, so still I don't understand why is this causing a problem. So if you look at this picture, and you saw it earlier as well, this is actually a picture taken from Dr. Thornton's research of a patient's muscle with a patient with DM2 who provided muscle tissue. So here you see the nucleus of the cell, and here this yellow dot is clumped up RNA. And then as a comparison, if you have a healthy cell, you probably can barely see it in the back there, but the RNA is more diffusely spread over the nucleus. So those clumps are called foci. And so now you say, well, okay, I have these clumps in my nucleus, in my nucleus, but why is this causing so many different symptoms in DM1 and DM2? And the answer is that these clumps trap important proteins, and as you learned earlier, those important proteins, they are like editors. They edit numerous other RNAs from numerous other genes. And so if those proteins are trapped, they lose function. And so they cannot properly edit other RNAs. For example, RNA from a chloride channel gene, and if it's not properly edited, then myotonia can happen. Then they don't edit properly RNA from an insulin receptor gene, and then diabetes can occur. If RNA from a calcium channel gene is not properly edited, muscle weakness can occur. And if RNA is not properly edited from a sodium channel gene, heart arrhythmias, conduction abnormalities in the heart can occur, and so on. And we haven't really exhausted that list in our understanding which, misplicing or wrong editing is causing what, but those are just examples. So that explains why DM1 and DM2 are multisystemic diseases and affect so many organ systems. So now let's shift to DM2. And as you heard, the registry is a great resource in learning about how the disease affects people with DM1 and DM2. And now we have nearly 20 years of follow-up, and I will show some graphs throughout this presentation. And for all of you that are already members of the registry and that have filled out and donated your time to fill out the surveys every year, thank you. Your answers are in that graph. So we learn from you how the disease is affecting you. And one thing we learned, so in DM2, the age at symptom onset when people first develop symptoms is typically 38 years old on average. And then the age at diagnosis, as you heard earlier, on average is 50. So people have the disease on average 12 years without having an explanation for it. I don't have to explain you what that means. Now, and what negative consequences that can result in. And I just want to mention a lot of patients get misdiagnosed with fibromyalgia or just pain syndromes or just malingering maybe even. It can be very hard. And so arriving at a definitive diagnosis is very important. Now, I will shift your attention over to this graph here because I'm going to show graphs like this throughout the presentation. And these are graphs that utilize data from the National Registry. And usually on the y-axis here, it reflects the likelihood of developing a symptom or a sign. And on the x-axis, you see age. And so 1, for example, means, for example, for disability, that a person has, that all patients are not disabled, and 0 would mean down here that all patients are disabled. And so you see, over time with age, DM1 are reflected in the red curve, and DM2 patients are reflected in the green curve. These are over 900 patients with DM1 and over 200 patients with DM2. You see that disability due to DM is more common in DM1 earlier in life, but that it's shifted towards older age in DM2. And then, of course, we get into retirement age, so disability is a little harder to measure at that age. Overall, our impression is, as you may know, DM2 is considered a milder disease. You may say, well, it's not affecting me mildly, and we agree it's different. And oftentimes what we realize is that it's more shifted towards older age, but can affect individuals in a severe way as well. And I'll provide a little bit more data to demonstrate how it affects people in the registry. So how do your doctors, what should your doctors look for? How should you be monitored? We talked a little bit about cancer screening, EKGs, et cetera, before. So some of this will be repetitive, some will be new. But let's go through it system by system. And we'll start with the most common symptom, which is the muscle weakness. And as you know best, the muscle weakness is different in DM2 than in DM1. It's what we call proximal, which means that the muscles closer to the trunk are affected. So, for example, neck muscles are quite weak, and oftentimes, as we learn early on, the shoulder muscles and the hip muscles are weak. And what does that mean to you? Well, difficulty climbing stairs, difficulty getting up from a chair or from a ground, or getting things from the cupboards can be symptoms. And oftentimes we hear that people initially think it's older age or arthritis or so until it becomes evident that there might be a muscle problem. Consultation with a neurologist, neuromuscular specialist, and we heard a lot from Dr. Eichinger already about assessments. And we heard a lot about avoiding inactivity and moderate intensity exercise, so I won't repeat myself there. I think avoiding falls is important. As you can imagine, if you're hospitalized for a hip fracture, that can really throw you back. And rehab might be more challenging for someone with muscle weakness. And home modifications may be necessary, as well as assistive devices as needed. And I just want to make one interesting comment on the optimistic study, which was DM1, so not DM2, but it turns out that that there were more falls with people becoming more active, and we don't know why that is, but I think just keep in mind that if you become more active, it's always in a safe way, and consider avoiding falls. So what did we see in the registry? Here you see a graph indicating use of a walker. Again, here no one uses a walker. Here everyone would use a walker. And you see with increasing age that DM1 patients use a walker earlier in life, but DM2 patients use it quite frequently later in life. About half of patients at age 70 use a walker. So the curve here is shifted towards older age. Similarly with wheelchair use. Now let's get to muscle pain, and that's more, to me, that seems to be more of a DM2 specific problem, because a lot of patients describe it to me as burning pain in the thighs, sometimes with activity, and but it can also be neck pain, neck and shoulder pain or back pain. And that's why, not uncommonly, patients get misdiagnosed with fibromyalgia. In fact, I just saw a patient this week in the research study, and he he's the first one in the family who got diagnosed because someone stuck a needle in the muscle and saw myotonia. But his mother is likely affected, and which diagnosis does she carry? Fibromyalgia and cataracts. So she's now being evaluated. So treatments, we don't have a targeted treatment, unfortunately, yet, because we don't know exactly the molecular mechanism for why the pain occurs. So treatments are, supportive. For example, conventional, if there's a lot of joint pain related, ibuprofen, Tylenol, not recommended on a daily level, a daily basis. Duloxetine can be tried. I would avoid opioids because of the GI side effects with opioids. PT, really important, an assessment, find out the areas of pain. Maybe some of the pain can be counterbalanced by exercises, specific exercises to strengthen other muscle groups. And then, for example, if there's truncal weakness, it's hard to walk upright, and patients lean forward, sometimes using high walking sticks, excuse me, for example, can help. And then discuss with your doctor whether treatment with statins may have worsened pain. Then it might be reasonable to try to come off the statin and just see if it makes a difference. And if it does, consider alternate therapies or a lower dose or treatment on alternating days. If not, then you can resume the statin. Also consider treating myotonia. In DM2, the myotonia that's very prominent oftentimes in DM1 in the hands with, the delayed opening of the hand, fist, is less obvious in DM2, and we think it's a lot more common in the proximal muscles, so in the shoulder muscles and the hip muscles, but it's not as easy to see. And so if you have pain that's really worse in the morning, when you get up, it gets better with activity, it gets worse with cold weather, it might be reasonable to consider treatment for myotonia and just see what it does to your pain. And that brings us to myotonia treatment, which is the same as Dr. Heedwell outlined with mexillatine and ranolazine. And I agree that it's good to have you should have an EKG checked first and evaluate whether it's safe to take mexillatine or ranolazine. Now, heart disease you already heard about. You may not have any symptoms. You may have symptoms, and those could include dizziness, palpitations, chest pain, heart racing, up to passing out spells. And either way, an EKG is indicated. If you have no symptoms, an annual EKG is necessary. If you do have symptoms or you're older than 40 years of age, the care guidelines recommend to see a cardiologist. And it was already outlined that the heart muscle is not most of the times the problem, but the wiring of the muscle, the electrical wiring of the heart. And as we talked about, there's conduction blocks, so the conductance of the electrical stimulus can be blocked along the way. And that's monitored by the EKG, which reflects how the electrical stimulus travels through the heart. And in some instances, when there's severe heart block, a pacemaker is indicated, and that's a conversation with your cardiologist. And when we look at the registry data, what our patients tell us is that, again, DM1 patients in the red here oftentimes have a pacemaker placed earlier in life, but DM2 patients follow at older age and sometimes need a pacemaker as well. So it's important to keep up on that. Now, respiratory weakness, sleep disorders, daytime sleepiness. I put this all on one slide because all of these things may appear or may cause similar symptoms, and it's our job to kind of figure out what is the cause. So just to sum it up, increased daytime sleepiness, feeling really groggy in the morning, having morning headaches, having to take several naps throughout the day. That's what we call daytime hypersomnolence or sleepiness, can be a cause of 3 possible explanations. So one could be that the respiratory muscles are weak. One could be that there's obstructive or central sleep apnea. And one other cause could be that it's just DM affecting the brain and sleep regulation. And what's important is to figure out which one of the three, or even a combination of the three it is, because the treatment is a little different. So for example, we do pulmonary function testing. It's recommended every 2 years, and for sure when you're first diagnosed, it should be done with the forced vital capacity in the office to see how your breathing function is when you sit and when you lie down. And why is that important? Well, the diaphragm is your breathing muscle, and when you sit, when you breathe in, it goes down, and when you breathe out, it goes up. And when you sit, gravity helps you, and so it's easier for the diaphragm to move down when you breathe in, while when you lie flat, gravity is taken away, and the gravity doesn't help you breathe. So it's not surprising that oftentimes when there's a little bit of respiratory muscle weakness, such as diaphragmatic weakness, that it first manifests at night when your diaphragm has to work harder at night because you're flat. And that's why we check forced vital capacity sitting and lying. Now, sleep apnea can only be detected by a sleep study, and we often recommend that. And if none of these items, when everything checks out fine, no sleep apnea, normal breathing function, then, it's possible that the DM is affecting your brain and the sleep dysregulation. And then it comes up to sleep hygiene, modifying your day as good as it's possible, or even considering stimulants, which is a careful discussion with your doctor. And going back to that question earlier, does it help to modify your sleep rhythm? I learned from my patients, and I've had one patient, for example, she just has a higher sleep requirement, and I've had a number of DM2 patients tell me that they have a higher sleep requirement. So they just need 11 hours or 10 hours every night. But if they do get those hours, they do relatively well. So I know it's hard to incorporate 10 hours of sleep into a work-life balance, but as much as you can try to accommodate that can help things, and to educate your family and your environment that's part of the disease and not just being lazy. And so that's sleep. Now, lack of sleep, being tired all the time, kind of automatically goes to mood, energy, and cognition, because if you're not rested in the morning, if you don't sleep well, if you don't get enough sleep, because you just need more sleep because you have DM, then fatigue, depression can occur, and not to mention having no diagnosis for 12 years on average can also result, I believe, or I would imagine, in mood issues. So what I hear a lot from patients is that they feel like they have a brain fog or difficulty with thinking and memory. And in studies, it seems like problems in DM2 are less severe compared to DM1, but are still detectable, and I think further research is necessary, and that's what we do in our natural history study as well, to understand that better. First, if someone has these kind of issues, I still think it's very important to address whether there is a sleep apnea problem or sleep or respiratory issues, because those are treated with non-invasive ventilation, with the little mask that you wear overnight that helps your diaphragm to breathe in and out, and you don't want to miss that. And then if that checks out normal, though, have a conversation about antidepressants or counseling, such as cognitive behavioral therapy. Cataracts, you may not have any symptoms from cataracts, but it's important to have an annual eye exam with your ophthalmologist to look for them, and the eventual treatment is, as you know, cataract surgery. And then GI symptoms, I always learn that you're the experts, and each time I talk to a patient about GI symptoms, I learn something new. But it can affect the entire GI system, from swallowing down to reflux, abdominal pain, constipation, bloating. Gallstones are removed earlier in DM patients compared to the normal population. And I've had patients where this was symptom number one on the priority list. So we understand this is a big issue. Treatment-wise, it's, sometimes it's good to see a gastroenterologist, but it's supportive with dietary modifications for diarrhea, loperamide, and then treatments for constipation, and that oftentimes needs to be individualized because there can be alternating diarrhea and constipation, and nutrition consultation if indicated. Diabetes, interestingly, I've always said the curve is shifted to older age for DM2. Well, you see here that actually it's the opposite. So patients with DM2 seem to develop diabetes more than and earlier than patients with DM1 according to our self-reported registry data. So that's important to monitor every year with a fasting glucose or an HbA1c. Anesthesia surgery, I can just repeat what Dr. Heatwell mentioned. I just have to say there's not much information for patients with DM2, but since we have a lack of knowledge, it better be safe and kind of follow the same guidelines that apply for DM1, which is careful with sedating medications. Patients might be more sensitive to sedating medications. There might be more difficulty breathing or swallowing after procedures. There might be more GI symptoms, specifically avoid opioids because they can cause more constipation and severe complications. And then you might have increase of myotonia and more pain potentially after coming out of an cold OR because myotonia gets worse when it's cold typically. And then cardiac arrhythmias, of course, is important to mention and be monitored by your doctors. And then pregnancy, again, a lack of knowledge. We don't know enough about it for DM2, but Dr. Cefaloni actually will be speaking a little later, has done research in that field, and it seems that some women with DM actually experience their symptom for the first time during pregnancy, and sometimes symptoms can get worse during pregnancy. Miscarriages seem to occur more often, and a subset of women can develop premature labor. In the studies have shown that UTIs were more frequent, so that's something to mention to your doctor. And have your doctors just be aware of the diagnosis and learn from you. Cancer, a question already was raised about cancer. So there's not enough information, excuse me, we have to learn more about how cancer affects people with DM2. We know the studies are mostly focusing on DM1, but in generally it seems that there is an increased risk, and the cancers that are increased is melanoma. So I would recommend typically to see a dermatologist annually just for a skin exam. Cancer of the uterus, thyroid cancers, and testicular and colon cancer are more frequently seen. Thyroid cancer, how do you monitor for that? We don't have a good answer to that because it's not part of cancer screening to look for thyroid cancer. So I looked into that, and there is a study looking into does it make sense to do ultrasounds, frequent ultrasounds in patients with DM1 to look for thyroid cancer. And so what they look at is if we do frequent ultrasounds on patients with DM, do we save someone by detecting the cancer early? And there's no final answer to yes or no. It still needs further study. I think if at all, an ultrasound every 3 years, that's what endocrinologists do. If you do notice any change in the size of your thyroid gland or so, I think that's worth mentioning to your doctor. But that's still up to debate how to monitor for thyroid cancer. Otherwise, age-appropriate cancer screening, as we heard earlier. And then when you look at this graph, again, this is what our patients reported back to us in the annual survey, whether they develop cancer or not. It seems with increasing age that there is an increased development of increased risk of cancer, and just that's kind of interesting because DM2 tracks right with DM1. So I would have the same recommendations for patients with DM2 as for DM1. And I think we defer questions to after Dr. Cifaloni's talk. Thank you very much for your attention.